Good morning. I'm Stephanie Caterson, and I'm the Chief of Plastic Surgery at Christiana Care Hospital and the Helen F. Graham Cancer Center.
And I'm Dorothy Bird. I'm a plastic surgeon here at the Christiana Care Center for Reconstructive Plastic Surgery.
Thank you for having us speak this morning for you at the annual Delaware Breast Cancer Coalition update. We're happy to talk to you today, and we're going to be speaking to you about pursuing breast reconstruction after mastectomy or not, and what your options are. So we thought we'd keep it fairly casual today. We were going to do some back and forth between the two of us, and we'll talk about questions that we often are asked here in the office and things that we're sure to cover when you come in for a plastic surgery consultation. So we thought it would be great to start with, Dr. Bird, should I have a breast reconstruction or not?
Oh, that's a great question. So with breast reconstruction in general, there are three different options. There is a flat closure, there is implant reconstruction, and there's flat-based reconstruction. So no, you do not have to have a formal reconstruction. A flat aesthetic closure is when we help the breast surgeons after the mastectomy tailor the skin on the chest to create a flat closure so it's easy to wear a prosthetic breast inside of your bra. This can happen on one side or on both sides. Sometimes we'll do a lift on the other breast if a mastectomy is not performed to give symmetry to a prosthetic inside of the bra.
And often we can even have a prosthetic ready for the patient at about even 6 weeks after surgery. So it's not long after the procedure that they can be fitted for a prostatectomy, correct?
Absolutely, absolutely. It's probably the fastest and easiest way to complete the breast cancer surgery with minimal downtime and minimal time added on to the surgery.
And with that in mind, I often am asked, is every patient a candidate for reconstruction? And I'd say most patients are. So, by the time they come to see us, they're often screened by our colleagues, the breast surgeons, but they're sent to us to consider those options. We'll review your medical history and make sure that it's safe for you to go forward with reconstruction. We'll talk to your multidisciplinary cancer team to make sure that they feel that it's safe for you to go forward with reconstruction. It's very rare that we would, from a medical standpoint, recommend no reconstruction or a delayed reconstruction, but we'll work with the cancer team to make sure that it's safe to move forward.
What if I'm not a candidate for reconstruction at the time of mastectomy?
Great question. So it will depend on why you're not a candidate, but some people either choose no reconstruction or are found to not be medically optimized or healthy enough to go forward with reconstruction at the time of mastectomy. And if that's the case, we can always consider delayed reconstruction. So there's many things that we can do to work with that patient to get them overall their health improved to the point where they can pursue reconstruction at a later date. Often that will be after their cancer care is complete, so they can move forward with mastectomy, have a flat aesthetic closure. They can use a prosthetic or not as they go through the next steps of their cancer care, which may include other things, including chemotherapy or radiation therapy. When their cancer care is complete, then we'll move towards talking to them about delayed reconstruction.
Sometimes even years after the mastectomy, a woman can come back to us and say, I'm ready for reconstruction now.
Yep, I've seen patients who are 10 years out from their mastectomy and choose to pursue reconstruction at that time. Maybe reconstruction just didn't seem like something they could face at that time. Often in younger patients, they're very busy taking care of a family or working and don't want to go through extra surgical procedures, so they choose to pursue reconstruction at a later time.
The other form of reconstruction, or another form of reconstruction, is implant-based reconstruction. So Dr. Caterson, what's involved in implant-based reconstruction?
Well, there are many things that we talk about with implant reconstruction. It's often a two-step process, so we often use a tissue expander first, followed by a permanent implant at a second phase. And going into making those decisions depends on the patient's breast size, what their size goals are after surgery, and the type of mastectomy that they're going to have. So, but most often a patient is using a tissue expander first, and then that's followed later by a permanent implant. And we have some samples here I'll hold them up towards the screen so we can see. This is a tissue expander. It is a temporary device. You can see that it is kind of like an empty bag. It's flatter on the back, and there's some tabs here on the back. These tabs have little suture holes in them that we actually tack down to the chest wall. And this disc right here is a metal disc that is within the device itself. When this is implanted into a patient, we can go over top of their skin and access this fill port through the skin using a magnet to find the little metal disc in here. So we can inject saline into this device, and it's usually filled with saline. And this is a inflatable device, so we can fill it in little increments and get the skin to stretch out. That is later usually replaced with a permanent implant. And this is what an implant might look like. This is a silicone gel implant. It is a soft device, very soft and squishy. It has a more flatter surface on the back and a dome surface on the front, and sits up against the chest wall like this. So,
this is the other kind of an implant. The patient has a choice between which kind of implant they prefer if they choose implant reconstruction. And this is the other kind of implant. This is a saline implant. It's still a silicone shell, but instead of being filled with silicone gel, it's filled with saline or salt water. And it's also soft and squishy, but it has a different feel than the silicone gel. You'll talk to your plastic surgeon about which one is right for you.
Are implants safe? I've heard some people mention that there are some risks associated with them.
Yeah. The most important thing to know about breast implants is that they are not lifetime devices. The average breast implant lasts about 10 years. Now, it's not like changing the tires on your car. You do not automatically have to change them out after 10 years. But on average, after about 10 years, things can happen to the implants that require them to be removed and replaced. One thing that can happen is something called capsular contracture. Your body forms a capsule around anything that goes inside of it, whether it's a breast implant, a pacemaker, a hip replacement. That capsule forms around anything that goes inside. And in the case of breast implants, sometimes that capsule can slowly shrink down over the implant and squeeze it. If that happens, it can make the breast look not as nice. Sometimes it can be painful. And that might be a reason why a woman would want to switch the implant out over time. We don't know what causes capsular contracture, but radiation increases the risk of it. So if you've had radiation before, it's worth having an extra discussion about implants and radiation.
The other thing that we can see with implants that I often will discuss with patients is just the general wear and tear over time. So because of this general wear and tear, this is why the FDA recommends that implants we get imaged and monitored closely. Usually we start with imaging at about 5 years after implant placement, and we image that implant every 2 years thereafter. That imaging is either an ultrasound or an MRI, whatever our radiology team recommends. We look at the integrity of the implant. What they're looking for is this lining around the implant to make sure that it's intact. And what I'll often describe to patients is that you can imagine that the implant is soft and it may have some natural folds in it. And depending on how the implant's positioned on your chest wall, when you take a deep breath in or move a certain way, you may be creasing that implant back and forth in the same area over and over and over and over again. So as that happens over time, just like when you break a credit card, it may weaken this lining around the implant. And over time, this outer lining of this bag surrounding the implant may get a crack in it. And if that happens, the gel on the inside may become exposed to the outside. Now, the gel that's in here and the type of implants that we use is a cohesive gel. So if we took this implant and we cut it in half and we turned it upside down, not much would happen. The gel does not drip out of it. It's not thin and runny like a hair gel. In fact, it's very thick and very thick and sticky. It sticks to itself. If I squeeze the implant, the gel would bulge out. If I let it go, it would suck back up into the implant. So if the outer lining gets a crack, the gel doesn't really want to go anywhere. It will stay within the implant, but that it may increase some scar tissue on the outside, and our recommendation would be to replace that implant if there is a break in the outer lining. So we keep a close eye on them over time.
Dr. Caterson, do breast implants cause breast cancer?
So Breast implants do not cause breast cancer, so that is very well studied, and there have been many short and long-term studies that look at breast reconstruction in general, and if it causes breast cancer or if it can prevent the detection of breast cancer in the future. Breast cancer recurrence can happen in certain patients, and honestly at any time. Most breast cancer recurrences are going to happen at the skin level, so that'll be very visible and right at the skin level. It's not caused by the implant, but the implant can be in the same area as the breast cancer recurrence. A deeper chest wall recurrence can also occur, and that could happen either above or below an implant. We tell our patients that the best surveying is really knowing their own bodies, just like it is for patients without breast reconstruction. So we don't do routine imaging beyond as far as mammograms or breast cancer screening, but their breast cancer patients are followed very closely by their oncology team, both from the plastic surgery standpoint, their surgical oncologists and their medical oncology team, to keep an eye out for any changes after reconstruction.
What about other cancers associated with the implants?
So there has been a cancer that has been associated with some types of breast implants. It's called ALCL, which is an acute large cell lymphoma. And large cell lymphomas have been found to occur in certain types of implants. So the implant that I was showing you here is a smooth surfaced implant. So you can see that this surface is very smooth. There's no texturing to it at all. The ALCL occurrences have happened in a different type of implant with a long-term exposure. So those implants are textured implants. There's different reasons why we might have chosen a textured implant in the past to use for patients. However, the texturing process and what we believe happens in certain patients, and we don't know why certain patients are not, they have found to be at higher risk for developing a lymphoma around that implant. That lymphoma normally happens at about 6 to 7 or 8 years after the implant's been placed. So it's a long-term exposure to a textured implant. And in fact, the FDA has recalled all of those implants. So no one is putting those implants in at this point. So the risk of ALCL with the implants that we're using now is extremely, extremely low.
Great.
What about other types of reconstruction? Are implants my only choice?
No, there's another popular form of reconstruction called flap reconstruction. Now, flap means transplanting tissue or moving tissue from one part of the body to another to rebuild the breast. And in the past 10 years, the most common form of flap reconstruction is called the deep flap. It's also called a muscle-sparing free tram, and the difference between those is really subtle. But we can rebuild a breast using tissue from the lower abdomen. That basically works because we know where the blood supply to the tissue in the lower abdomen comes from. At the time of the removing the tissue expander and doing the final reconstruction, we can take that tissue from the lower abdomen with the blood vessel that supplies it. We tease that out of the muscle, and then we transplant that up at the chest and use a woman's own tissue to rebuild the breast. What keeps that tissue alive, what keeps that flap alive, is the blood vessel that we sew together. And so we have to monitor the blood supply very closely to that flap afterwards. As you can imagine, all of this tiny surgery takes a lot of time. So it's a much bigger surgery than an implant surgery, but it's a nice durable result that looks and feels like a woman's breast, much more than an implant can. But it's a bigger investment of time up front for the surgery, and it's a much longer recovery as well too. But it's an important option, especially for women who've had radiation before.
What are the risks associated with that? Is that always successful?
Yeah, that's a great question. Not everybody's a great candidate for the deep flap reconstruction. A couple of important things. The most important thing is we need to make sure the blood vessel supplying that flap is open and working. Sometimes women who've had surgery on their abdomens before have had that blood vessel injured, in which case we need to talk about a different option. You're not a good candidate if the blood vessel has been cut through. Other issues, people who are smoking, we know have much higher risks of complications for this. So in order to be a candidate for the flap surgery, you have to quit smoking. We also know that higher BMIs are associated with higher complications, so it's important for the BMI to be 35 or less in our practice to be a good candidate for the flap reconstruction, just for safety. Other people with blood clotting problems are also not encouraged to do the flap because the blood vessel that we sew together is so tiny. People who have coagulopathies or blood clotting problems can be at a higher risk of flap failure. But overall, in someone who meets the criteria, the flap success rate is about 98 to 99%. So if we do this surgery 100 times, 98 or 99 times, things are going to be just fine.
That sounds like a great option.
It is a great option. It is a great option.
So I think, you know, in summary for the general options, we typically would offer patients, you know, the first thing we discuss is no reconstruction and what a flat aesthetic closure may look like, what we could do to the contralateral breast for symmetry. We'll discuss implant-based reconstruction options and what the steps are that may go into implant reconstruction. We'll also discuss the flap options for patients, and most commonly that flap is a deep flap using the tissue from the lower abdomen to reconstruct the breast, and that requires no implant at all. So it's a implant-free type of reconstruction. But all these sound pretty extensive, and you know, a lot of patients come in and ask me, is it going to be painful? Mm-hmm. So luckily here at Christiana, we're able to work with our anesthesia colleagues very closely, and for all of our reconstruction patients, we utilize different types of pain management techniques that start from before you even have surgery. So the morning of surgery, we start with some pills that will help do anti-inflammation and some nerve pain management. And then we'll also do regional nerve blocks. So the anesthesiologist will use an ultrasound and they'll put a long-acting numbing medicine into the chest area, which will block the nerves into the breast area. So it will be, you know, virtually numb in the chest area for several days after surgery. And during that time, you're continuing to take the anti-inflammatory medication and the nerve medication, which will help keep those nerves calm. And so when the nerve numbing medicine starts to wear off, it's almost as if your body didn't even recognize that you've had a major surgery. So most of our patients go through these procedures with absolutely no narcotic use or no opioid use, which I think is a very impressive development that has happened throughout my career with breast reconstruction.
Mm-hmm. I agree. I think most of our patients take Tylenol, an anti-inflammatory, and sometimes a nerve pain medication, and most of our patients are very comfortable with that.
How about after surgery? Do patients have to limit their activities, and is that forever, or can they get back to doing everything that they like to do?
We would love for patients to get back to everything they do in the future. The most important rule after surgery is no heavy lifting, pushing, or pulling with your arms. Nothing more than 5 pounds for about 6 weeks after surgery. That using the arms for heavy lifting just tugs on the chest wall a little bit too much, and we don't want you to accidentally pull a stitch or tug a muscle. And so gentle range of motion is encouraged, but nothing heavy or vigorous. So we usually discourage things like vacuum cleaning, playing golf, painting a wall, gardening. Wait at least 6 weeks. Once a patient gets to the 6-week mark, you can gradually increase the activity, always listening to your body. If it feels like it's too much, it is too much.
A lot of patients will ask me about drains. So drains are often the things that are the most annoying after surgery, and unfortunately they're a necessary evil in most of the types of procedures that we do. We use drains that are thin tubes that go through a hole in the skin and near the edge of the reconstruction and go into the surgical site. They connect to an external bulb, and that bulb will draw the fluid out from the surgical site away from the body and into the bulb. And right after surgery, that fluid is prevalent there, and we're recording those numbers, so we're knowing how much fluid your body's making. As the body starts to heal and the tissues where we've operated start to stick down, the drain numbers will start to decrease, and we're able to get rid of those drains. But while the drains are in place, we have a special dressing on the skin, right where the drain comes out of the skin, in order to allow patients to shower after surgery. So in our practice, patients are allowed to shower immediately after surgery. And we have a drain sheet where patients record the output of the drains, and they're in close contact with our office. So when the drains are ready, they're able to come in and get those drains removed as quickly as possible. But the drains are often the worst part after surgery and unavoidable.
Yeah, nobody likes their drains, but they do their job, and they're very important.
They are, absolutely. Is there any patients that you've met that reject implants? Is that something that we see?
Oh, it's a common question that I get. And the truth is no. Your body cannot reject the implants. The term rejection refers to a specific cellular response that cells in your body have to foreign cells. For example, a transplanted organ carries the cells of the donor, and the patient's own cells might reject those donor cells over time. The breast implants that we use have no cells in them, so your body can't actually reject them. I think what most people mean when they're talking about rejection is usually an infection. And infections can happen after surgery, although they're pretty rare. Overall, the infection rate is about 2 or 3%. If an infection happens, it happens most often after the mastectomy and the tissue expander. That's the most vulnerable time in the tissue expander's history in your body, because the blood supply after the mastectomy is lessened, so there are fewer blood cells to fight infection. Infections after you've healed a few weeks after the mastectomy become less and less likely.
Another common question I hear is, what will my breast feel like after surgery? And I think that is, it's a complicated question, because there's what the breast feels like when one touches it. So when you touch and feel the breast, what will it feel like? And I think that it feels two different ways depending on the type of reconstruction that you undergo. In implant reconstruction, you'll mostly be feeling this implant underneath of the skin, and it feels almost like a stress ball. It's soft and squishy, but it is filled with a silicone gel, and feels kind of like that stress ball when you squeeze, and can kind of squeeze the gel around. Now, sometimes breast implants can also feel cold. They don't have a blood supply to them, so you may be touching that breast implant from the outside, and your hand is feeling an object that feels fairly cold. That is not true with a deep flap reconstruction or any type of flap reconstruction. Flaps are using your own tissue, and they have their own blood supply. So typically the flap reconstructions feel very natural. They feel like your own tissue, and if you would squeeze the tissue of your lower abdomen, that's what your breast is going to feel like when the breast reconstruction is finished. So that's one way of describing how your breast will feel after surgery. The other way to look at it is, how will my breast skin feel, and will my breast feel like a breast? So the breast itself will actually be very numb after surgery. The nerves that come up to the breast skin and to the nipple area travel through the breast gland. So during the mastectomy, those nerves are cut and removed from the body with the breast gland. So the edges of the skin and the edges of the chest area are still connected and have nerves there. Those nerves will grow up and into the skin. But initially after surgery, a lot of the skin of the breast is very numb. So that's something that I think is important to remind patients of, or review with patients ahead of time, so they're prepared for that sensation after surgery.
And nerve regrowth is a very slow and unpredictable process. Some people, the nerves can grow back slowly over time. Other times they don't grow back at all. And that's an area of active research in plastic surgery right now, is how to restore sensation. But we don't have a good answer for that yet.
Mm-hmm. Yeah, I think that nerve regeneration is something that can happen over the course of years after reconstruction. Mm-hmm. So it's something that you can see a patient for their first visit, for an annual visit, and it's been a year since they've had their procedure, and they may be fairly numb in their chest. but the next year when you see them to check on their reconstruction and check in with them, they may have, increased sensation, but they don't notice it themselves as much because it's almost like watching hair grow. You don't see it happening yourself, but it does happen very slowly over time, and often patients will get improvement. So there is hope to get recurrence of the nerves to regenerate over the course of 3, 4, 5 years after surgery.
Yeah, absolutely. It can take many, many years. My favorite question that I get, Dr. Caterson, is what about the nipples?
It's a great question. So what about the nipples? So this is a conversation that includes your breast surgeon, the breast surgical oncologist. And we start that conversation with our first initial consult. In some patients, if the cancer is very close to the nipple, then the nipple must be removed from a cancer standpoint, from a cancer safety standpoint. If the cancer is far enough away from the nipple that it seems safe that the nipple may not be involved, then the decision of whether to keep the nipple or not with a mastectomy kind of falls back to the plastic surgeon in discussion with the surgical oncologist. We often consider things such as the shape of the breast, how large the breast is, and where the nipple is located. Is the nipple symmetric to the other side? And review these things with patients. So we'll be looking at patients from an individual standpoint, and especially how their body is shaped and how their breast is shaped, as to considering if they're a nipple sparing candidate or not. So if we can spare the nipple, we can sometimes do that at the initial surgery. If we can't spare the nipple, then we can create nipples down the road. So whether you've had an implant-based reconstruction or a flap reconstruction, we can use the skin of the chest area or of the flap to lift up a little skin flaps, wrap them together, and make a bump that is an actual bump of a nipple that will protrude from the body. After that's healed, we can do a nipple and areola tattooing to give the pigment back to the nipple and areola area. Several patients choose to not pursue a bump of a nipple because they may not want to have that bump that sticks out. That's very common, I think, in patients that have had bilateral reconstruction and they have a smooth surface, and they may enjoy not having a nipple to have to cover up. And especially with an implant reconstruction, a lot of women choose to not wear a bra after that surgery and don't need to. So they may choose no nipple reconstruction, however, want the look of a nipple and areola. And for that, we can offer a nipple and areola 3D tattoo. I think later this morning in the program, you'll be hearing from an expert in the field who's going to be speaking to you on that. And it's an amazing option for patients.
Great. I think that about wraps up our time here.
I think it does. And we're very happy to have been here this morning. We hope that you have a wonderful morning with the rest of the presenters. And we hope that we were able to offer some clarity on the process of deciding to pursue breast reconstruction or not after mastectomy.
Absolutely. Yeah. Thank you for the invitation. We hope this tells you how breast reconstruction can complement excellent breast cancer care. Thank you so much.
Have a wonderful day.